So our 2 lectures, this is gonna be in canvas here. You got your mechanical ventilation lecture, and then you should have your arterial blood gas lecture, what we just went over, and 2 separate videos. But it should be posted in canvas now. Your podcast thing that we normally do is all of it together. Same with your study guide information. It's going to be in there as well. This ABG quick guide interpretation is the piece of paper that I printed out for y'all. So if you have it for reference, if you lose it or something like that, it's there for you as well. And then this arterial blood gas quiz gives you a ton of different options out here for quizzes. Gives you all kinds of questions. And so very good resource for you. And then you'll go through, click through it, and just kind of quiz yourself. I really like this website. So pH 7.53, CO2 of 40, that's going to be a little bit off, and then bicarb is 32, so that's metabolic alkalosis, right? All right, CO2 is 40, that's normal, so no compensation, right? And then this last one, don't let this one throw you off. We're not getting it that advanced with it. That's if for bicarb or your CO2 is off one way or the other, and it's gonna treat that. So at the very end, it tells you your response, you check your answer, and then it'll say congratulations, you're correct, and then it'll give you a breakdown of why it's correct, okay? And then go to the next one. That's ABG Ninja is what this is called, and it has several other quizzes on here too. It'll pull you to here first, and it has all kinds of stuff. But arterial blood gas is what you're going to shoot for. And every time you go into it, it gives you a little bit different values. So that's a good resource. And then I'll print your lecture out, or put your lecture up there in a little while. You have your study guide up there all ready for you. And then there's 2 different things for your chest tube content as well. There's a quick guide that gives you a picture and it breaks down each of your little sections here as well. And then there's another one that just says chest tube management. So this is going to be everything you need to assess, the things you need to do as a nurse to take care of your chest tube. And then it also gives you some emergency actions as well right here at the bottom. When to notify a doctor, that kind of stuff. Okay. Good. Second half of our gas exchange. We're going to break it down a little bit. Pneumos and hemos. We're also going to talk about the management of those, which is mostly going to involve your chest tube management, so chest tube care. And then we're also going to talk about different types of lung surgeries, what that involves. And a lot of the management for that is also going to involve chest tube management as well. So chest tubes are going to play a big role in kind of the second half. And then we're also going to talk about ARDS, or acute respiratory distress syndrome. All right. Just overall, just thinking about a pneumothorax, just an overview, what does that mean to me?
Unwanted air.
Unwanted air within the intrathoracic cavity, right? More specifically, in this parietal pleura, right here on this outer edge. So you have your ribs, your rib cage right here, your intercostal muscles. There's a little section or little piece right there. We're gonna have some type of trauma, some type of damage, some type of separation of that parietal pleura, and that's what's gonna cause that pneumothorax. That's what's gonna allow that air into that intrathoracic cavity to develop something like a pneumothorax. Two different causes, two different types. So either some type of disruption of that parietal space or that visceral pleura right there, or the rupture of the alveoli itself within that lung space. Overall, your general signs and symptoms, depending on the severity of your pneumothorax. So if it's a very small pneumothorax, just a small amount of air that has developed outside of the lung space into that intrathoracic cavity, your patient may not experience a whole lot of symptoms. As that pneumothorax progresses, the more air that has accumulated inside that chest cavity, that's when I'm going to start to see these symptoms and a progression of these types of symptoms, all right? And eventually, if that air space is taking up too much, it can collapse my lung as well, and then I'll have a whole lot of other issues as well. So things like shortness of breath, some type of chest pain, some type of chest discomfort. If you hear chest pain, yes, we think about heart, but we also have some other options out there as well. So think about that. Tachypnea, my patient's trying to get more air into their lungs. They feel that shortness of breath. They're gonna breathe a little bit heavier, a little bit faster, trying to compensate, trying to get that air into their lungs, all right? If I have a big pneumothorax where there's not much lung space or my lung has popped, am I going to hear breath sounds on that one side? Probably not, right? Okay, if my symptoms have progressed even further and I haven't assessed my patient in a while and they've developed these over a short period of time, then I can get something even further. If I have not relieved that pressure or that air from that system, the intrathoracic cavity, I can get something like a tracheal deviation because so much air has accumulated. We're also going to talk about hemothoraxis, so something like blood has accumulated within that thoracic space. It's pressing up and pressing everything over past that affected side. So let's say I have a right-sided pneumothorax, so I have a bunch of air accumulating on that right side. It's going to push my trachea past that midline, and it's going to push it toward the left side because all of that pressure is pushing it the other way. And so you'll see that on your patient, and that's going to be kind of those late signs. Other things to think about. Remember when we were talking about PEEP, and it's causing an increase in that intrathoracic pressure, which is decreasing my cardiac output overall. Same concept. If I have too much air in that thoracic space, it's causing pressure on that heart. So it's going to decrease my cardiac output, which is going to cause that hypotension in there as well. Okay? Several types of pneumothoraxes to choose from, whatever your flavor is, but depending on how it occurs is how we're going to classify this type of pneumothorax. So we can break it down into spontaneous, which can also be breaking down a little bit further into primary versus secondary. We can have traumatic, so that can be either even an open injury or a closed injury. And we also have something called a latrogenic injury as well. And then the last one's going to be just a tension pneumothorax. And that's what we're going to refer it to as. So let's talk about a spontaneous pneumothorax. For some reason or another, whether it's primary or secondary, it's going to be that disruption of that visceral pleura. So remember that little lung tissue right on the outside, right on the edge of that lung space. And it's going to allow air into that intrathoracic cavity. Usually it's going to originate somewhere within the lung tissue. All right? With that, primary. No prior lung disease whatsoever. Nothing that should cause this to occur. So it's just spontaneous. It just happens out of the blue. Somebody can be just walking around and it just happens. It just occurs. That's your primary spontaneous pneumothorax. The people that are most at risk, tall, thin, lanky, white males. All right? So somebody that's just real tall and, what'd you say, Drew?
Anna didn't have to look back.
You're not young, so.
Oh.
Alright, usually young, tall, thin white males, right? Josh, you're out too, you're too short, you know, so just-
I was never worried about it.
Okay, alright, so, but usually that's when it's gonna happen the most. So you'll go on to 2 Southwest or CTC and you'll see these 23-year-old guys with chest tubes. Why? Because they had a spontaneous pneumothorax. It's just kind of weird to see that young of a population have something like a chest tube. You think they should be pretty healthy overall, but it just happens, it just occurs. Okay? Then we have a secondary. So secondary is gonna be some type of prior lung disease, maybe some type of lung cancer, some type of COPD. Anything that's gonna cause a change within that lung tissue. So the spontaneous pneumo is secondary to that main malfunction, to that main concern. And that's what we wanna think about. So again, with your spontaneous, it usually originates from the lung itself. It's not from an outside source. It's not from the outside atmospheric pressure that's rushing in. That air is leaking out and escaping from the lung tissue. So that's your spontaneous pneumothorax. Let's talk about a traumatic pneumothorax. So remember, we gotta classify these into 3 different types. We have an open, a closed, and a laterogenic. With your open, some type of penetrating chest wound, some type of trauma. So big things, some type of knife stabbing, some type of gunshot wound, maybe some type of motor vehicle wreck or some type of workplace accident where they fall on a pipe or something and it causes this open wound. It's introducing that hole into that pleural space, causing a pneumothorax within that enterothoracic cavity. Big things with this, 3-way dressing, initially. So initially we're gonna do that. We're gonna tape it down on 3 sides, allowing for that 4th side to kind of flap open. In theory, as that patient breathes in, it's gonna collapse down and create a seal or a barrier, not introducing that air back into the enterothoracic cavity. And then as they exhale, it's going to breathe out any of that excess air that has accumulated within that pneumothorax. And so that's our goal with that 3-sided dressing. That's very temporary though. More long-term, we're gonna put in a chest tube to drain out that excess air and any excess drainage that we might have because of that trauma wound. And then we're gonna have surgical repair of that hole, of that pleural space to hopefully seal that off. And that's our goal with our open pneumothoraxis. Another thing, closed, a closed traumatic pneumothorax. So it's on blunt force trauma. Blunt force trauma. Nothing penetrating. So maybe I fell. Or again, maybe a motor vehicle accident, but it hasn't punctured that enterothoracic space. It has caused a separation of that parietal space. And now it's introducing air into that enterothoracic cavity. But I don't have an open, gushing type of wound with that. It's a closed type injury. So if it's a closed injury, this 3-way dressing is not gonna matter because there's nowhere for that air to escape at because there's no open source hole. With that, the main thing I'm gonna worry about is chest tube placement. And then your laterogenic, for some reason or another, during that diagnostic procedure, so maybe a central line insertion, that's a big one to cause a pneumothorax. That's one of our biggest concerns when we put in a central line is a pneumothorax. And so maybe I nicked that pleural space on entry, or maybe I was doing a needle biopsy for some type of lung cancer, and I caused an injury to that parietal viscera, that pleural space right there, and caused a pneumothorax. So your laterogenic is going to be your procedure-based type of things that has caused this traumatic type of pneumothorax. Overall, with these pneumothoraxes, you gotta think about our normal breathing cycle. Remember, it's that negative pressure gradient that's allowing that air into our lungs every time our diaphragm contracts. And then as it relaxes, we're exhaling because it's trying to match the atmospheric pressures. So with those open chest wounds, it's trying to match those atmospheric pressures. That's why there's such a big gush of air into those lung spaces. The last one we're going to talk about is a tension pneumothorax. What you'll remember, emergency situation. All right, it's highlighted right there for you. This is an emergency situation. There's so much pressure that has developed within that intrathoracic space that is causing airway compromise. Remember that you might have some tracheal deviation because of so much pressure that has developed. Maybe there is so much pressure that is pressing against my heart, so I have such a decrease in my cardiac output, or it's causing my lung to collapse. There's a couple of different things that it could cause. How am I going to treat it? Needle decompression. Now, is Natalie allowed to take a blunt tip needle into her patient's room and stab her patient in the chest? No, this is not a nurse's scope of practice right here. Do not stab a needle into your patient's chest because they think you have a tension pneumothorax. You will get in big trouble for that. This is a physician thing. This is a nurse practitioner type of thing. You may see medics or something out in the field do this as well. But if you are a nurse, you do not do this. All right. But they're going to take roughly a 14 gauge needle, a pretty good sized needle. They're going to put it within that second to third intercostal space, and then they're going to press it down. And as soon as they do, you'll hear the air gush out. You'll hear this just kind of hissing sound. It's really cool. I just like the sound of it. I like when they put in the chest tubes too, and then you make an incision within that space. You can hear all that air hissing out too. Pretty cool. So, again, let's review what our patient is going to look like. Remember, a tracheal deviation, that cardiac output. Other thoughts, hypoxemia. They're not ventilating, they're not oxygenating like they should. Our patient's gonna have those signs and symptoms of that respiratory distress. So what would they look like? They would look rough. Let's be more specific than rough. Respiratory distress, what we got?
Like we call it on the muscles, the extra muscles, trying to get.
Those intercostal
Yeah.
muscles, all right, good, I like that. Are they gonna be, what position are they gonna be in? Tripod position, trying to get a good breath of air in, good. What's their skin look like? Cyanotic, right? Maybe their lips will be cyanotic as well. We might have a low SpO2, low O2 sat, all right? I like this picture a lot. It's kind of funny to me, but this is what a tension pneumothorax is supposed to be about, all right? So for some reason or another, air is entering my pleural space, all right, pressing on against this other lung. So he's trying to whisper, because you can't hear those breath sounds, hey, is that chest tube in yet? Because chest tube or needle decompression is going to be my big thing for that tension pneumothorax. So let's review for our pneumothorax. Remember, air in the pleural space. That's our big thought with that. I'm going to have some hemodynamic instability. My vital signs are going to be off. You're going to notice those things when you do your assessment. They're also going to be hypoxic, and you're going to note that. Initial treatment is going to be that 3-sided dressing if I have an open wound. If I don't have an open wound, our next step is going to be a chest tube. That's 3-sided dressing. Don't cover that on 4 because it's not allowing that air to escape like it should. And then like I said, last thing is gonna be that chest tube insertion. So just another good representation of what I'm talking about with a pneumo. Have all your symptoms on the left side here. What can cause these types of things? This is several options. So you have open wounds, you also have your laterogenic as well. And then you also have your secondary type of pneumothoraxes as well. Okay. And then how would you diagnose? So if you walked in, your patient is in respiratory distress, what are some things we're gonna think about? Why is my patient in respiratory distress? Is there any type of diagnostic things that we can consider, think about? What would y'all think when you walked in and saw respiratory distress? What's our first thought?
Pulmonary embolism.
Pulmonary embolism, good. What else? Smoking exacerbation or COPD exacerbation, probably, yeah.
Asthma attack.
Asthma attack, good. How am I going to know those things?
Look and see if they have asthma.
Aspiration, good. Maybe they choked on their eggs. Those little watery eggs, they love to choke and aspirate on those eggs, all right?
Sounds coming from that room last night.
Yeah, your patient's room had, yeah. And so I'm gonna listen to their lung sounds. Probably gonna have diminished lung sounds on one or the other. And then I can start to think, well, that maybe sounds like a pneumothorax. How can I definitively tell, besides listening to their lung sounds, if they have built up air in that pleural space?
You can touch it and see if it has like crevices.
You can have that as well, but the big thing is a chest x-ray. I can't look and see if there's air in that space, all right? So I gotta get a chest x-ray. It also is gonna sound like a drum or that hyperresonance as well. So if you beat on your patient, remember that tactile phremesis way back when in first semester, and that's the only time we ever did it in school. That comes back into play as well.
Yeah, unilateral rise and fall.
Unilateral rise and fall, good. So several options out there. Questions about a pneumothorax?
I have one. So like, I know it takes a while to get an chest x-ray and stuff. How long do these patients have when they start getting pneumothorax before it becomes like life-threatening? Like, just like give or take, I know.
It really depends on how fast that this is progressing. Hopefully you've caught it early enough and you start to see a steady decline in your patient's respiratory status, and you've got this on board anyway. But if it's a slow moving, progressing pneumo, it can take several days before it fully progresses to that point. And sometimes they resolve on their own, so they could have a small little pneumo and you really don't have to do a whole lot of intervention, but then it just resolves on its own. So. Okay. So with attention pneumothorax, call that physician. Get ready for that needle decompression. Throw some oxygen on them. Make sure that their head of their bed is in a high position. You don't want them flat, right? That's gonna cause more respiratory distress on them. Let's help them out a little bit, all right? So probably need to know your attention pneumothorax type stuff. Hemothorax. We're gonna change gears. Hemothorax. So what does hemo mean?
Blood.
Blood. So blood within that interthoracic space, in that chest cavity. You can have something as a really serious type 1 or a massive hemothorax. So you have greater than 1,000 cc's of blood in that cavity. That's a lot of blood. All right, or maybe a small one. So less than 1,000, you're getting way down there. You can get like 25, 50, 100. You can get real small accumulation of blood within that space. You can also have other types of accumulation of different things within that pleural space that could cause a potential thorax. So you can have like an empyema, so there's just kind of infected pleural fluid. You could have buildup of lymphatic fluid as well. So there's several different things that could build up to cause pressure in that intrathoracic cavity. Signs and symptoms. It's going to be very similar to your pneumothorax signs and symptoms. Other thoughts though. Hypotension and shock. They're losing a large amount of blood volume into that intrathoracic cavity, into that intrathoracic space. So with that, I'm going to have tachycardia because my heart is trying to compensate for that low blood pressure, that hypotension. And so that's going to become one of your big differences there. Those late signs for your pneumothorax, you may also have this involved as well. The only way to really tell is going to be on something like a chest x-ray. And it's going to show the difference of air versus some type of fluid in my intrathoracic space. What's going to cause it? Some type of chest trauma. Usually some type of stabbing or some type of gunshot wound. Maybe they've had a football injury where they broke a set of ribs and it's created a tear or something within that pleural space. So then you have an accumulation of blood within that. What am I going to do for it? How am I getting that blood out of there? Chest tube, right? Again, all of these interventions are really going to go back to chest tube management. So chest tube management is probably going to be important for this exam as well. So chest tubes. You're going to have some type of atrium. So some type of collection cavity. This one's a real old one, but it's there. That's going to collect your blood within your atrium. And then you're also going to have some that have a water seal in it as well, where you're going to pour sterile water in it, and you'll see that. Then you'll hook it up to wall suction. So very similar to this one on the far right over here as well. But the main thing is we're going to insert we're going to have a little incision, and then we're going to insert that chest tube within that pleural space to drain out that excess air, to suck out that excess air, to suction off that, and then also drain out that excess blood or any drainage that might be present within that intrathoracic cavity. So it can be used to drain a whole sorts of things. So pneumothorax would be air, your hemothorax, blood. I said that empyema already. That chylothorax right here on the bottom one, that's your lymph fluid. Several options, several sizes out there. So something like 12 to 20. The higher your number, the bigger the size. So it's kind of opposite of your IVs. Within this setup right here, you have your collection side. So that's where any of your excess drainage or blood's going to occur. This is going to be your water seal down here at the bottom. And then that's where you're going to notice your tidling and your bubbling that's going to occur. And we're going to talk about tidling and bubbling in just a second with our management. And then you have this little accordion, this little orange accordion right here that's going to show if your suction is adequately working, your wall suction is connected appropriately and adequately causing that suction or that seal. And this is how we're going to control the amount of suction that's going to occur. So it's -10, -20, -30. Everything is usually set at -20 to start with. This is a physician order. Whatever the physician says, that's what we're going to set it to, and then we're going to leave it there. When he tells you to change it, you can dial it up from here. And then the back side here, you got your tubing that's going to be connected directly to the patient itself. And then right here, this little blue tip is going to be where the wall suction connects to create that suction seal from there. With this is gonna be a physician or nurse practitioner that's trained to put these in. That's who's gonna put these in. They're gonna look at the chest x-ray and other types of imaging. Maybe they got a CT scan or something like that. And that's what's gonna determine where along the intrathoracic space that they're gonna place this chest tube at, okay? With these, we have other options too. We can actually send people home on a chest tube management system if they have frequent reoccurring pneumothoraxes or have reoccurring fluid that has developed in their chest tube or in their pleural space. But do I want to carry this around all day, every day? Do I want to go to Walmart and carry this around? Probably not. I'm sure they would, but probably not. And so, I have something called this Heimlich flutter valve. Looks something similar to that. The way this valve is designed, it allows that air to escape on exhale, and then as it inhales, it closes back down, closes back off, to not allow air to be reintroduced into the thoracic cavity. So it's a specialty valve that allows for that direction of the airflow. I don't want to introduce air in, but I want air to come out.
Is that the same guy who did the Heimlich maneuver?
I don't know, maybe. I'm sure Mr. Heimlich was pretty smart at one point. If it was his name was Heimlich, I'm not sure.
So that's only for pneumothorax, not a pneumothorax?
You can usually just do it for a pneumo. Hemothoraxes, they normally won't. They have some type of other setup. Sometimes they'll have a little pigtail, something similar to this, and that's actually kind of like an injection port. And so they'll come in every so often and get it drained or excess out, or the home health nurse will come out and pull a little bit of fluid off every so often and do it that way. Okay. So,
Could you take a JP home?
you could potentially take a JP drain home. Yeah. What is our role as a nurse for chest tube insertion? Have you ever thought about that?
Assessment.
Assessment, all right? So we're going to assess before we put it in, right? And we're going to note that we have that decreased, diminished breath sounds on that one side. The patient has become hypoxic. They're showing those signs and symptoms of respiratory distress. So then I'm thinking maybe I need to get a chest x-ray to confirm that something is occurring. And so then at that point, I need to get some stuff ready. So I can get all this stuff. I can get my chest tube tray, I can get the chest tube itself, get my atrium ready, and get my patient prepared and ready to go. I don't think I have a picture of it just yet. But whatever side's affected, my physician has got to have easy access to it, right? So if let's say I have a left-sided pneumo, I want to turn my patient to that right side so my left side is nice and visible for my physician. I also want to get my, say my left arm, since it's on the left side, up and kind of away from that sterile field. He wants a nice visual picture of the axillary and kind of that whole sternal side right there, so he can pick out each individual rib there, that each intrathoracic space, so he knows exactly where he wants to make his incision and do that placement. During this procedure, I'm looking at those vital signs. Some physicians knock their patients out a little bit. They'll give them a bump of something just to calm them down, or if they're out of it, you won't have to worry about it. But a lot of times they'll give them like a touch of propofol or a touch of Ativan, just something to kind of help them relax, kind of knock them out a little bit, make them a little bit sleepy, so they can do this procedure. So during that time, I'm looking at my O2 sat, making sure that it doesn't decrease, making sure my blood pressure doesn't drop. That's what I'm doing while he's fixing to insert this. I can also help with the sterile procedure, opening up those packages for him, getting those things ready. As he's inserting this chest tube, I've got to get my atrium ready, because he's going to ask for it as soon as he puts that chest tube in. As So you gotta get this all ready. You gotta put the water in the atrium. You gotta put the water right in here. You gotta get the wall suction hooked up and placed on your atrium, making sure it's in the right setting. So like a -20 right up here at the top. And then you're going to sit there, and as he's placing it, he's going to ask for this other side. You're gonna hand it to him because it's a sterile procedure, and he's gonna place it and hold it kind of within that chest tube. All right, so it's two different parts. This is not the part that goes in the patient. All right, there's a chest tube itself, and then I'm connecting it to the chest tube. So it's two different pieces. And then we'll create that seal around it, making sure I don't have any air leaks. Okay. And so that's usually my job as a nurse. He's going to sew that in, put some sutures in, so hopefully it doesn't pull out, fall out. And then we'll get a chest x-ray to make sure it's in that right spot. Maybe he'll want to move it to a different spot. So usually we'll get a portable chest x-ray in there. They'll shoot it. He'll look at it and say, I don't really like that placement. Or maybe I can float it up a little higher to get it in the exact spot that he wants it to be at. That's a little better look at this atrium right here on the -20, -30, -40. Like I said, usually you're gonna start out at -20 suction. Physician's gonna tell you that, and then you'll bump it up if you need to. Know this slide, okay? Big things, drainage greater than 100. Greater than 100 in an hour. So I'm talking like 200, 300, 400. That's a lot of something in an hour, right? Well, so let's talk about a hemothorax. That's a lot of blood in 1 hour. I need to let somebody know. Maybe it's a continuous bleed that my physician needs to go in there and correct so I don't have so much bleeding. My patient is losing a lot of volume through this chest tube. I gotta let somebody know so they can fix it. Also note the color. If it's bright red, maybe it's arterial. If it's dark red, maybe it's just old blood, and the physician is expecting a lot of old blood to come out initially. Or maybe it's cloudy. It's real dark. Maybe there's some type of infection that's happening within there. So let's note those things. Let's talk about how to measure this drainage. So I've had several questions recently on how to actually measure these. So depending on your hospital policy is how often you're going to assess this. Usually when they come out, they're gonna assess it like every 15 minutes for a while, and then they'll go to every hour, every 2 hours, every 3, then every 4. But on this one, your drainage is gonna come into this first chamber right here. As it fills up, it gets all the way up here to this 250 mark. Once it gets into that 250 mark, it dumps over into this next chamber and it starts filling up. All right? You're not adding this amount of volume to this amount of volume. It's continuous. All right? So as it dumps 250 and it gets to 300, I'm not adding 300 and 250. I just have a total amount of drainage of 300. Okay? I've seen several people do that before, so don't keep adding it. And then as it keeps going further, you may have 2,400 of total blood. If that's a bad thing, maybe that's happened in just a day's time. That's a lot of blood at one time. What if it's happened over 4 or 5 days? That's probably okay, right? So each time I go into the room to assess, I'm gonna mark where I get my drainage amount out. And then usually I'm gonna put like the time and my initials somewhere in there. But I'll just kind of mark and put a black line on it so I know from 12 o'clock to 1 o'clock, I only drained out 50. And then from 1 o'clock to 2 o'clock, I drained out 200. I need to know, let somebody know between that 1 and 2 o'clock hour that I've drained more than 100 mils per hour. So then when Chuck comes in for night shift, He knows my last amount of output, and I'll tell him too, I got out this amount today, I got out 300 total today. I marked it at 900 for the last one, so anything above 900 is gonna be yours. So now Chuck goes in, and now he knows anything above 900, I've gotta count in my total amount. So he knows if it's 200 more, so it's like 1200 or whatever, he knows that my patient is bleeding a lot, and he needs to let somebody know for his shift, okay? Remember, where does this atrium have to be? On the floor, right? I'm not hanging it up on an IV pole. Never seen that done before, but please don't do that. Don't hang it on an IV pole. It's gotta be below the patient's chest. I gotta have that gravity system draining out that fluid. Do not milk or strip your tubing. This tubing right here, specifically. So we're not milking it. So we're not pulling on it like this, kind of like you're milking a cow. All right? Or stripping, trying to get these excess blood clots to come out or get that excess drainage. You may have a significant blood clot that you need to get out, but you need to let a physician or a nurse practitioner do that for you. Once you become a little more seasoned nurse, sometimes the physicians are comfortable with you, even if they're at their bedside, it can allow you to get some of those clots out. I can create more force or more pressure that's gonna send it back into my inner thoracic cavity, causing more damage from there. And also, if you're not careful, you can potentially just pull it out altogether. So there could be some complications with that. So don't milk or strip your tubing.
On one of the quizzes that you had, the before test quizzes, it says, it was a true or false, it said you can gently milk it, and I put false because everything said don't milk, and I got it wrong.
Okay.
So can you gently do it, or no?
As in gentling, you can just like pick it up to allow for the gravity. Testing purposes, no milking, no stripping. Okay. What kind of supplies do I need at bedside? Y'all remember that from chest tubes?
There
Here, hemostats or clamps. I need sterile water. What else? Gauze dressing. All right. Why do I need sterile water?
In case it comes out.
In case it comes out, right? So if my atrium gets disconnected from the chest tube itself, chest tube is still hanging out, right? What is this atrium doing? It's creating that water seal, right? So if I have that sterile bottle of water, I can put it up and put my chest tube in that sterile bottle of water. What am I doing? I'm creating a water seal from that. So it's going to allow that air to come out. So you'll see bubbling kind of in that little sterile water bottle. And then it should not allow air back in. Now it's not going to allow for any drainage or anything because there's not a drainage chamber, but temporarily, because this is an emergency situation, until you can get another atrium, get it set up, get it ready to go to plug back into your chest tube, that's what I'm going to use, okay? Now, your dressing. That's if the chest tube itself and everything comes out. So chest tube and all comes out of your patient. Remember, I gotta do that 3-sided dressing. I'm creating that kind of flutter valve almost. Allowing that air out through that 4th side, and as I'm inhaling, it's gonna create that seal, not allowing air back in to that intrathoracic space. What are my hemostats for?
To clamp.
Am I going to clamp my chest tube itself? No, right? You don't want to clamp it for a long period of time. We're going to say not at all. Because then, what if your patient goes next door? Y'all get real excited about codes and y'all go running off to that. And then my patient has had their chest tube clamped for 7, 8, 9, 10 hours because you forget. All that blood, all of that air is accumulating within that pleural space. And now I'm causing a tension pneumothorax. And now my patient is in respiratory distress because of that clamp. Ways to use my clamp: it can detect an air leak, so I can slowly clamp my tubing further and further down. If I still have continuous, strong, vigorous bubbles in my water seal chamber, I know that my leak is further down my chest tube, because it's allowing air into my system. And then once I clamp it a little bit further down, if I don't have any continuous vigorous bubbling, I know in between that section of tubing, I have some type of air leak, some type of seal problem that I need to address. Okay. Questions about emergency type stuff for chest tubes?
Why don't we have a box of diapers up there?
Yeah,
Yeah.
I'm trying to figure this out.
I had to ask too, because this isn't my PowerPoint, this is Dr. Carty's PowerPoint, that I stole. The Pampers. And so if the patient is sent home on one of those flutter valves that causes some excess drainage or draining fluid out, and they can't afford multiple atriums, or Medicare or Medicaid does not pay for those, they can wrap them up in the newborn diapers, and it causes to absorb that excess drainage.
Oh, seems a little unsanitary.
It works. I mean, it's like a little newborn swaddler diapers, you know, they have the Huggies movers, so you know, if you're on the move, you can get those. No, honestly, it's just there to collect that excess fluid and drainage.
That was funny, is it? You know, pamper the chest too, like.
Sorry, I completely forgot there was a Pampers picture up there. Yeah. Let's talk about troubleshooting. So things that can go wrong. Now, titling, is that okay?
Yes.
It's okay, right? So as I'm inhaling, as I'm exhaling, that titling is going to occur. I wish I had an actual atrium, but let's see. Hard to see it. But I'm gonna have titling occur. So there's gonna be a little white ball that's gonna be in this water seal chamber. And then as I inhale and as I exhale, it's gonna slide up and down this water seal chamber. So I call that titling. That's normal. That's fine. That's okay. But if I don't see it no more, I have some type of kink or clog or something within my system because that air is not moving in and out of my system. So maybe my patient's rolled too far and they kind of kinked off this tubing a little bit. Remember, I want this kind of nice dependent looping. I don't want nothing hard and harsh where it's clamping off a bunch of times. Or maybe you hung it off the bed the wrong way and now it's clamped like this. Maybe you did use your hemostats in the inappropriate way, and so now it's clamped off altogether. So several options for that. Bubbling, is that okay?
Mm-hmm. It's good. Some of it's okay.
Depends on how much, right? So if I have that vigorous, constant, continuous bubbling that's just real harsh, so it's just like, I mean, it's just constant, continuous, within this water seal. So down here at the bottom, I mean, it is violent. You're gonna be able to tell that it's continuous, vigorous bubbling. That's a problem, all right? Some reason or another, in my system, air is being introduced. So as that wall suction is suctioning, it's actually suctioning part of that air leak from that outside space. So it's causing for that continuous, vigorous amount of bubbling to occur. And depending on it, there's actually numbers on here as well. There's a 1 through 5 setting. And if your bubbling gets to this far left side on this 5 over here, then that you can also determine how vigorous or continuous, how violent your bubbling is. Now, if it's just intermittent bubbling, or just kind of a slow, not really just every now and then type of bubbling, that's okay. That's just air escaping from my enterothoracic cavity. So if I have a pneumothorax, remember that's air within that enterothoracic space, I'm going to expect a little bit of air to escape through my atrium. That is the intended purpose of that chest tube. So that's what I'm going to expect. Okay? All right, dislodging. So So we're gonna apply a sterile zero-form gauze. So everybody's seen that yellow petroleum type gauze in clinical? That's that zero-form gauze. So some type of petroleum gauze to that wound itself. So that's if that chest tube comes out all together. And then I can also create that three-way tape seal. Now if it disconnects from the atrium, so remember the chest tube is still in my patient, but the atrium itself has been disconnected, that's when I'm going to get that bottle of sterile water to create that water seal. Wait for that new atrium, wait for it to get set up, and then I can kind of plug it back in to my chest tube, creating that seal. As I'm troubleshooting these types of things, I'm starting with my patient, and then I'm working my way down. Start with your patient first, work your way down. All right? Please know your troubleshooting type things. How would you fix this if you had some type of issue with your chest tube?
If you're able to fix it, did you still call someone?
Yes. You don't want the physician to come in like, what happened? Yeah, and so I always tell somebody, put it in an error note, hey, this is what happened. The more you charge, the more you're gonna cover yourself. So if there's any type of legal issues, you go to court for something, you have documentation. But the more you charge, the better off you are, usually.
So does the zero form go, where does the zero form go? Cause you got, does it go around the floor?
Yeah.
Over it?
Like over.
That's what you're making the flap out of.
No, you're creating the
Flap over the gauze. The zero form goes under.
zero form goes under the gauze,
Uh-huh,
and it's still gonna allow air in and out, right?
okay.
Because it's, has little spaces. I mean, it's like gauze, you know, it's gonna
Okay.
cause, allow air to escape. And you're gonna put the three-way.
Okay.
All right, other things. Subcutaneous emphysema or crepitus. This is what Natalie was talking about earlier. So this is where air has been introduced into the skin tissue, that subcutaneous area. So not quite in the intrathoracic space, but pretty close. Remember, this is that Rice Krispie type feeling as you're palpating along the skin around that insertion site that you're gonna feel. You're gonna feel kind of that popping, crackling feel for it. Remember, pneumothoraxes, any type of mechanical ventilation is gonna cause this type of issue. Anybody need a break or we keep going? Keep going. All right, let's go into lung surgery.